Wishes to all. I think we got off to a very good day yesterday, covered many topics, many of them quite unique, and I think we have a very good group to present to us all day on some of the most important issues that this organization deals with. So I'm very pleased and I'm looking forward to a most interesting morning. We're going to start with talking about lung cancer, and although we will miss Olivier Mir, I'm so pleased to have Jeff Crawford from Duke University to present to us on this topic, of which he is one of the most knowledgeable experts in the world. So let me call upon Jeffrey to get us started off to a very good day today.
Dr. Gralla, thank you very much for that kind introduction. I'm not sure I'd quite qualify as a world expert in this topic, but I'll do my best. Good morning, everyone. Bonjour. So what I'm going to try to do is talk a little bit about what the original speaker would have talked about, which was the impact of immune checkpoint inhibitor therapy, not only in lung cancer, but really across cancers. We touched on this a little bit yesterday in the case discussion. And fortunately for me, I've taken some of the information from the original speaker's slides, but most of what I'm going to show are slides that I developed, or my fellow developed with me. So in the theme of junior doctors and cases, I'm going to really review this from the standpoint of a case we saw together at Duke and the ensuing talk that developed from this. So the objectives today will be to present a case, to define the immune-related adverse events, talk about them in relationship to CTLA-4 and PD-1 blockade. We'll discuss the management of common immune-related adverse events, and also what happens in terms of clinical outcomes if you do use immunosuppression, and the outcomes with the adverse events themselves. So this was a case we saw on our inpatient service. It was a 50-year-old woman who had a thyroidectomy and was diagnosed with metastatic clear cell renal cell carcinoma. She underwent a nephrectomy and then underwent 4 cycles of concurrent ipilimumab and nivolumab. After those 4 cycles, she went on to a maintenance and had just received her first cycle of nivolumab after the combination. This may be a little hard to read, but she presented to the emergency department with 6 days of generalized weakness, dysarthria, dizziness, confusion. She had an isolated cranial nerve 7 palsy. Her primary care physician had prescribed steroids and acyclovir for what they initially thought might be a Bell's palsy, but she had never taken that. If you scan down to the neurologic symptoms, the patient had weakness on facial examination. She also had some weakness in the upper extremities. She was areflexic in the lower extremities. When you look at her chemistry, she was hyponatremic, had mild renal insufficiency, some elevated liver enzymes, and impressively, her cortisol was low. It did not stimulate with colchicine, and her ACTH was also low. A lumbar puncture was performed. She had nucleated white cells with predominant lymphocytes, an elevated protein, normal glucose. Flow cytometry was done on her lymphocytes. They're predominantly T cells. So we'll come back to the case, but let's talk a little bit about the current checkpoint inhibitor therapy available. In the United States, it's ipilimumab, which is a fully human IgG1, as well as tremelimumab, which is a fully human IgG2. Ipilimumab is available in our country, but the second agent is not. Ipi is approved for advanced melanoma, but is in widespread phase 3 trials, alone and in combination in other settings. Tremelimumab is looked at in lung cancer, head and neck cancer, as well as mesothelioma. The approved PD-1 agents in our country are nivolumab, as well as pembrolizumab. Both agents have approval for melanoma, and both agents have approval for lung cancer now, to update this slide a bit. with, again, approvals being sought in multiple other settings and uses, as we've discussed. So what are immune-related adverse events? They're adverse events that really are a result of this immune enhancement. When one has an immune checkpoint inhibitor, one unleashes the immune system, and that may result in over-vigorous immune stimulation. This is often an inflammatory process and generally T-cell mediated to self-antigens. This is a very commonly shown slide just to show the diffuse nature of the potential adverse events that can occur. Essentially, one can put the term itis on almost any organ, and that can be seen in the setting of immune stimulation, whether it's gastroenteritis or dermatitis, neurologic events, endocrine events, or other adverse events. And we'll come back and talk about some of these individuals. It might be interesting and instructive, though, just to talk first about mechanism of action of these agents. CTLA-4 is a negative regulator of T-cell activation. This serves as a physiologic brake. It's present on the cell surface of CD4 and CD8 T cells. Inhibition of CTLA-4 activates and proliferates CD4 and CD8 cells. So one unleashes the immune system by blockade of CTLA-4. With PD-1 and PD-L1, that interaction directly inhibits apoptosis of tumor cells and promotes T effector cell exhaustion. So by blocking PD-1, one can dampen, or by PD-1 itself can dampen the immune response of activated T cells. If one inhibits it, one restores an anti-tumor effect. So both of these are blockade of suppressive effects on the immune system to unleash the immune system to be able to better deal with the cancer. Preclinical models are also instructive. If one sees, looks at a knockout mouse of CTLA-4, one sees hyperproliferation of lymphocytes, diffuse lymphadenopathy, and death within 3 to 4 weeks with severe myocarditis and pancreatitis. If one has blockade or a knockout of PD-1 in mice, we see increased cellularity of both lymphoid and myeloid cells, moderate splenomegaly, but otherwise normal and healthy lifespan. So it gives you an idea of the impact of blockade of one versus the other pathway. To look at the immune-related adverse events of CTLA-4 blockade first, the common ones occurring more than 20% of the time, rash, pruritis, and diarrhea and colitis. Less common are hepatitis and endocrinopathies, which can range from hypophysitis to hypothyroidism to hyperthyroidism. Less common, episcleritis, uveitis is seen, pancreatitis, nephritis, neuropathies, as in the patient I presented. Lymphadenopathy can occur, thrombocytopenia, toxic epidermal necrolysis, and pneumonitis. So really a host of different inflammatory events can occur in different body organs with blockade of CTLA-4. A difficult slide perhaps to see, but essentially what this is trying to show is that in most of the studies of anti-CTLA-4 antibodies, some degree of toxicity is seen in as many as 70% of patients. So it's a very frequent abnormality to see at least rash or colitis. If one looks at the kinetics of this, the thing that occurs first is generally rash. That's followed by diarrhea or colitis, and that's followed subsequently by risk of hypophysitis or liver toxicity. So rash usually within the first few weeks, colitis usually within 4 or 5 weeks. And those are the two that we deal with the most frequently, and we'll come back to that. With the PD-1 agents, when one blocks that pathway, the events are less common, but one again sees rash, and less frequently, but one sees diarrhea and colitis as well, hepatitis, and again, endocrinopathies. Rare, or at least less common, are pneumonitis and anemia. So in melanoma, this is just from the phase 3 trials of nivolumab, showing the frequency of this PD-1 agent with diarrhea occurring in 8 to 22% and rash in 4 to 26%. You can see the rates of pneumonitis being less common, but potentially very severe and occasionally fatal. in a slide that's also a little difficult to see, but it's meant to show that when one uses combined blockade, one gives both CTLA-4 blockade as well as PD-1, then one really increases the rate of toxicity. So there is some synergy here, but you can see with nivolumab alone, the rates are relatively modest compared to ipilimumab, but the combination is quite high. So the grading system for this is typical of our other grading systems: mild, moderate, severe, very severe, and fatal, and needs to be applied very carefully in our patients to understand the potential severity. If we start with rash and pruritis, the rash is often, as I think we saw yesterday, discrete, erythematous. It's minimally scaling pruritic. These papules can coalesce together and really involve the trunk and extremities. Also, the face and head, palms and soles are generally spared, so it's often truncal in nature. Vitiligo can also be seen in a lower frequency of patients. There's some interesting data, but perhaps still premature, that patients who develop vitiligo on these agents might have a better outcome than patients that don't, again suggesting that this may be a marker in some sense of a benefit of the agent. If one looks at an algorithm for management, clearly the degree of rash will dictate what might be done. For patients with mild skin rash, just grade 1, moisturizers, topical interventions are enough, and therapy can usually be continued. For grade 2, topical steroids are clearly recommended along with other agents. If it's severe grade 3 or 4, we're talking about systemic steroids and discontinuation of the agent, at least until there's better control of the rash. If one looks at the diarrhea and colitis, again, one can see the higher rate of diarrhea and colitis in ipilimumab versus nivolumab, but it can be very serious in either patient population. And I think for us in the lung cancer community, we got very used to managing the diarrhea of tyrosine kinase inhibitors with Imodium and other agents. This is a very different phenomenon. If it's mild, one can use typical anti-diarrheal therapy, but if it's more significant, one really needs to use steroids and use steroids very quickly. So it's a very different algorithm, and one that if one doesn't act quickly enough can often lead to a bad outcome for patients. So it really takes the nurse talking to the patient or whoever's getting that first phone call to understand what the agent is the patient's on, if it's an immune checkpoint inhibitor, to have a very low threshold for immediate intervention. The endoscopic appearance of these patients who have colitis, interestingly, sometimes the infiltrates are neutrophilic, other times they're lymphocytic, or sometimes both. It's not clear that the outcome is different based on the type of infiltrate, and clearly the intervention would be similar with a low threshold for steroids. And this is just to show the typical pattern seen in patients with these inflammatory changes. So again, one wants to hold, for mild diarrhea, one can use loperamide and fluids, but with moderate, one needs to have a quick intervention with steroids. With severe involvement, one has to use steroids at a higher extent and level, followed by a taper. And for patients with really severe grade 4 diarrhea, this can be life-threatening. They need to be admitted to the hospital. They need systemic steroids at high dose. They need to be tapered slowly over weeks. And in those patients, the usual recommendation is to discontinue the drug permanently. It's also, in our country at least, more common now to use infliximab or TNF blockade early, because the steroids often by themselves don't ameliorate this, or when one tapers the steroids, patients will have a relapse. So we're using some other TNF blockade sooner in these patients than we did before. Now for the endocrine effects, hypophysitis due to pituitary suppression is not uncommon. It can lead to adrenal insufficiency, hypothyroidism, or one can have primary adrenal insufficiency, primary hypothyroidism, or immune thyroiditis. So really a whole host of different endocrine events can occur. Very important to involve your endocrinologist and also important for us to all learn endocrinology a little bit better than perhaps we knew before to sort through this. So again, these are events that in your cancer population you might not immediately detect. They present with fatigue, they present with other common effects, and you may not recognize that underlying this is hypothyroidism, hypoadrenalism, or some other endocrine deficiency. So we routinely will screen patients with TSH and have a low threshold for evaluation with cortisols in this population. Again, the evaluation in terms of the grading of the events are shown here. And other endocrine events, again, trying to get a sense for the frequency of these events. This is with nivolumab alone versus the combination versus ipilimumab. So in this series, it looks like nivolumab tends to have at least as much endocrine disorder as ipilimumab. So I think it is something to watch for. And clearly the combination seemed to have the highest rate. You can see the frequency of hypothyroidism, hyperthyroidism, and hypophysitis, with, again, the combination therapy being highest risk. So what is this hypophysitis? Is inflammation of the anterior pituitary gland. Patients can present with headaches, nausea, vomiting, fatigue, and diarrhea. But in the patients I've seen, it's generally been the fatigue. So it hasn't been a lot of other symptom complex that allowed them to be easily sorted out from others. And they can have enlargement of the pituitary gland on MRI. Growth hormone and prolactin are generally spared, but one can diagnose this as in our patient, but with a low ACTH level. So management, of course, if they have hypophysitis, is to manage the thyroid deficiency and the cortisol deficiency in this population, potentially the testosterone deficiency if that's present. Because they can present with adrenal crisis, early intervention with steroids is vital. For the hypothyroidism, when it's primary, that's often due to destructive thyroiditis. In these patients, they will have an elevated TSH, thyroid stimulating hormone, with a low T4. Secondary will be on the basis of primary failure of the pituitary. Hyperthyroidism can also be seen. So patients may also have high thyroid levels, again, in the setting of thyroiditis, and that can be worked up through thyroid panel and thyroid antibodies. Hepatitis occurs in a smaller percentage of patients, more common with ipilimumab than the PD-1 inhibitors. Again, monitoring these patients and trying to sort out other hepatotoxic medications is important, limiting alcohol intake, and of course looking for other causes of hepatitis is important as well. Here's, again, an algorithm for following patients with hepatitis and looking for intervention based on their degree of enzyme elevation. Again, I think the common theme is that grade 1 and 2, one can usually continue the immune checkpoint inhibitor therapy, but at grade 2, 3, 4, one is really intervening with steroids and trying to interrupt the therapy until there's improvement. So we could go through this with 10 other organ systems, but essentially there are similar scenarios here. There's uveitis or episcleritis, pancreatitis, nephritis, neuropathies as in our patient, sometimes with Guillain-Barré or myasthenia gravis, lymphadenopathy, thrombocytopenia and anemia, pneumonitis, Dr. Grall had mentioned yesterday in our discussion, and then a myocarditis, pericarditis, vasculitis. So the use of these agents really call upon all of us to be internists again, to really practice internal medicine, to really examine all organ systems, to think about all the potential complications that might be happening in a cancer patient who's already sick for other reasons. So in terms of the grade 3 and 4 events and clinical response, there's not evidence that, there's some evidence, in fact, that patients that have immune-related adverse events might have a higher clinical response rate than those that don't. So while it's an adverse event, in terms of dealing with it, it doesn't necessarily say the drug is not working. In fact, it may be that because the drug is working, they have more immune events related. So what about the impact of steroids? So we're talking about giving steroids to patients to suppress the immune system when we were trying to enhance the immune system to fight the cancer. So what's the impact of this? Well, this comes from a retrospective series of melanoma patients getting ipilimumab over a period of a few years. And they looked retrospectively to determine what the impact of this was related to outcomes in terms of overall survival, time to treatment failure. First, if you look at the impact of the adverse events and corticosteroids on overall survival, there was only one death in the setting of these adverse events, which was good, but many were very severe, grade 3 and 4. The treatment for these adverse events, 103 patients received steroids, most of them for grade 3 events. And you can see most of this for diarrhea, but hepatitis, dermatitis, endocrinopathies, uveitis, pneumonitis, all the things we've talked about were on this list. And some patients received additional immunosuppressant, including 29 patients getting infliximab, again, speaking to the need often for colitis to intervene early with other agents than steroids. If one looks at the overall survival and time to treatment failure, this is, I believe, for the overall group of patients. In terms of overall survival and time to treatment failure. If one looks at the group now divided by those that got steroids versus those that did not, you can see the group with steroids is in yellow, and their curve, survival curve in D at least, is superior to the group that didn't. So at least from this retrospective analysis, we do not have evidence that use of steroids to treat immune adverse events has a negative impact on overall outcome. And there may also be a positive impact prognostically on having that event, so that may balance out, but it doesn't look like we're impairing the outcome of patients if we need to use steroids. So let's return to our case. 9300 is our inpatient floor where this woman was admitted. She was started on dexamethasone 4 milligrams every 6 hours. Due to her LP results, she had 1 dose of IVIG. She was initially thought to have Guillain-Barré, but the findings of both white cells and the normal protein, or elevated protein, did not support that. She had a dramatic improvement with just the steroids and perhaps the IVIG. Within 24 hours, she was transitioned to oral prednisone and discharged with oncology and endocrine follow-up. She's been doing well since, has not gone back to other immune checkpoint inhibitor therapy. If you remember, she had 4 cycles of combined therapy and 1 additional cycle of nivolumab. Our final diagnosis for her was a grade 3 hypophysitis, grade 3 neurotoxicity. Our neurologist could not actually label what it was she had, but it fortunately resolved very quickly. So the conclusions from this talk are that immune-related adverse events are T-cell mediated inflammatory events. Very importantly, early initiation of immunosuppression reverses these events in the majority of patients, but it takes early recognition and a high threshold of sensitivity for this. As we've talked, CTLA-4 inhibition is more potent than PD-1 inhibition, both on the immune system, but also on the rate and risk of developing these complications. The combination of CTLA-4 and PD-1 inhibition seems to yield the greatest toxicity, and we have many, many trials ongoing now understanding how to use these agents together, so we have to be cautious. At least at this point, with the data we have, it does not look like glucocorticoids adversely affect outcomes, and it may be that grade 3, 4 immune-related events may be a positive prognostic indicator. So I will stop there, and I thank you.